Congenital coronary artery anomalies. Coronary artery anomaly has a wide spectrum of normal variation, which makes the definition of clinically significant pathophysiological coronary artery anomalies somewhat controversial. Osteostenosis, acute angle of takeoff from the aorta, ostial ridges, vessel spasm, intussusception, non-compliant pericommissural areas, arterial compressions have all been implicated. Many variations of coronary artery anomalies, such as circumflex artery arising from the right coronary, are without physiological impact, which makes an accurate assessment of the incidence of coronary artery anomalies difficult. Most estimates range from 0.1 to 1% depending on the population studied. Certain anomalies are more frequent associated with other congenital lesions, for instance, anomalous coronary artery pattern in 15-20% of patients with tetralogy of Fallot. Basic principle of coronary classification is the anomalous origin of the coronary from the artery is studied. Name of the coronary artery assigned is not according to the site but proximal course, but according to the dependent territory. A common proximal trunk which joins 2 or 3 coronary arteries is named a mixed trunk. RC is a vessel that crosses the right AV groove and provides the blood flow to the right ventricle free wall. LAD is the vessel that courses anterior to the interventricular groove and provides blood to the anterior interventricular septum, and circumflex is the vessel that courses AV groove and provides the blood to the free wall of the left ventricle on the obtuse margin of the heart. The anomalous origin of the coronary artery from pulmonary artery tree most commonly involves the left coronary artery, but occasionally right coronary is involved. The circumflex or both coronary arteries may arise from any of the central pulmonary arteries. Anomalous origin of the left coronary artery from pulmonary or artery has 3 or 4 variants. The common aortic origin from the right or left coronary artery. A coronary artery arises from the aorta at a location of other than expected sinus, and this includes the spectrum of the normal aortic anatomic variation. The potential anomalies include the anomalies from arterial takeoff, branching, numbers, and course. Anomalous course can be clinically significant as a course between the great vessels and create an external compression. The right coronary artery from left coronary sinus with ventricular arterial concordance, left coronary artery from right aortic sinus with ventricular atrial concordance. Anterior descending artery from right coronary artery crosses the right ventricular outflow tract, and the anterior descending artery arises from the proximal right coronary artery and courses across the right ventricular outflow tract. The intramural proximal coronary arterial course. The proximal coronary artery courses within the parallel to the aortic valve and before emerging to assume the epicardial course. A single coronary supply to all heart. Myocardial bridging of the coronary artery. A segment of the coronary artery, which is usually epicardial, is located within the ventricular myocardium and is susceptible to compression during systole. The congenital coronary arterial orifice stenosis, congenital coronary arterial orifice atresia. Then is the congenital arterial fistula. A coronary artery communicates through an anomalous channel with the cardiac chamber or with any segment of the pulmonary circulation. Communication may be simple or direct, or may be tortuous or dilated. In order of frequency, the involved coronary artery is right and the left, and rarely both the coronary arteries. Occasionally, the multiple fistulas are present, and congenital coronary arterial fistula to the right ventricle, the congenital coronary artery fistula to the left ventricle, and congenital coronary artery aneurysm, usually defined as a luminal diameter of 1.5 that of adjacent normal coronary arteries. And the coronary artery aneurysms are usually saccular, fusiform, or both may be a single or multiple. ALCAPA is the most common variation of the coronary artery anomaly originating from the PA. Anomalous right coronary artery is PA. ARCAPA and anomalous origin from both coronary arteries are extremely rare. The incidence of this is 1 in 300,000 children and male dominance of 2:1. With ALCAPA, the left ventricle receives the deoxygenated blood. Additionally, as the pulmonary artery diastolic pressure falls, the perfusion pressure decreases in the left coronary artery, thereby further exacerbating the LV ischemia and dysfunction. Furthermore, the coronary artery steal can occur due to the pressure differentials between the pulmonary artery and left ventricle, which in turn worsens the myocardial perfusion. ALCAPA should be considered and excluded in all the infants and dilated cardiomyopathy, as this is a treatable and potentially complete recovery of myocardial function. So, in the early neonatal period, there is a high PVR, antegrade perfusion of the left coronary in myocardial territory, and perfusion by desaturated blood from PA. Later in neonatal period, PVR falls, coronary perfusion pressure falls, and the myocardial perfusion depends on collateral from RCA. Further fall in PVR, flow in LAD becomes retrograde. Steal from the right coronary circulation, aggravating ischemia. Stenosis in the LAD origin at the point reduces the degree of the steal and confirms a degree of protection. So these are two types of ALCAPA, adult and a congenital type, infant type. Presentation is variable depending on the degree of collateralization from the RCA and the PA pressures. Often the PA pressures increase the coronary steal, but is generally within 4 to 6 weeks of life, and neonates may be present with a clinical range of discomfort and feeding to extremities with the signs of the profound heart failure, irritability and distress, and feeding indicative of angina, cardiac shock, sudden cardiac death. Adolescent and adults may present with the worsening dyspnea and fatigue with exertional angina. Patient often present with significant mitral regurgitation due to papillary muscle infarction and LV dilation. Clinical exam may reveal a murmur consistent with the mitral regurgitation. ECG may demonstrate lateral or anterolateral Q wave indicative of previous myocardial infarction and evidence of active ischemia. Echocardiography can show the origin of the anomalous coronary insertion from PA, and the color Doppler can demonstrate the flow reversal from pulmonary artery. Other clues of echocardiography include RCA dilation, severe dilated cardiomyopathy, hypoechoic papillary muscles, and the cardiac CT or MRI can be used to confirm the diagnosis if unclear. Particularly in pediatric patients, the MRI is emerging as an alternative to cardiac catheterization. Catheterization remains a gold standard confirmatory test but is reserved for the cases in which the other invasive tests are inconclusive. For older patients, catheterization may demonstrate the aortic root angiography and a single dilated RCA with the presence of collaterals for late retrograde filling and the left main coronary artery. A common scenario in adults with the chest pain undergoing the cardiac catheterization during the origin of the anomalous RCA cannot be found arising from expected location from the aorta. So ACAOS can show LV dilated, impaired systolic function, papillary muscles brighten due to infarction and fibrosis, mitral regurg, and Doppler assessment, RC is dilated. CT and MRI can be done, and cardiac catheterization can show elevated left ventricular and diastolic pressure. All ALCAPA patients require surgical intervention depending on the status of the patient. Mechanical circulatory support may be needed in the postoperative setting. The various surgical options include reimplantation. This is the standard of care for ALCAPA and can be performed in most cases. Anomalous coronary is excised with the rim of the pulmonary artery and anastomosed the aorta with re-establishing the two coronary circulation. The pulmonary artery can then be repaired primarily with a patch. Transpulmonary baffle Takeuchi procedure In short, the aortopulmonary window is created above the level of the sinotubular junction in the aorta. A PTFE patch is used to create an intrapulmonary tunnel and directing the blood from the aorta to the anomalous coronary ostium. And this technique has a significant risk in the long-term baffle leak and baffle occlusion, supravalvular pulmonary artery obstruction, and is generally reserved for cases in which the ostium of the anomalous coronary artery is so far away from the aortic root and reimplantation is not possible. Ligation of the anomalous coronary artery of purely historical interest, and this technique was previously used to prevent the coronary steal via the anomalous left pulmonary artery. However, it is significant perioperative and late mortality risk and does not resort to antegrade flow into the left coronary. So these are the steps of operation. Surgical outcomes are good. Anomalous origin of coronary artery from the opposite sinus of valsalva. The prevalence of this ranges between 0.1 to 0.7 and being 3 to 6 times more common than the anomalous origin of the left coronary artery. And however, anomalous origin of left coronary artery is more prevalent with the cases of SCD. Anomalous aortic origin of the coronary artery is generally the second leading cause of the sudden cardiac death in young competitive athletes after hypertrophic cardiomyopathy. The incidence of SCD is 0.1 to 0.1 per 100,000 person in large adults, and the risk of mortality over 20 years period for young children and athletes is 6.3 and 0.2% respectively. Out of those participating in competitive sport, the risk of SCD for symptomatic patient with AAOCA appears to be similar for those of AAOCA. So this is left circumflex artery from the sinus, and LAD from the right coronary sinus can happen. And there can be crossing pathways which could be retrocardiac, retroaortic, and preaortic. And the crossing pathways could be interseptal and precardiac. Some of the patient the occurrence of sudden cardiac death during the immediately following strenuous exercise is the first indication of anomalous origin, and still with the patients are diagnosed incidentally via echocardiography, CT, and any signs of symptoms of ventricular arrhythmia, dyspnea, angina, palpitation, dizziness, syncope. Clinical examination, ECG, chest X-ray are the part of the standard workup. Catheterization has fallen out of favor due to invasive nature of the exposure of radiation and generally reserved for instances for anatomy being clear and defined. Transthoracic echocardiography is used as a standard imaging modality. Cardiac MRI and CT are used as diagnostic adjuncts. These modalities also allow identification of intramural segment of anomalous coronary. Once the diagnosis is confirmed, the current recommendation for exercise testing, ideally combined with the nuclear perfusion and test or stress echo, and for the identification provocable ischemia, including competitive athletes, and these provide studies for low negative predictive value. The intervention is usually recommended in symptomatic patients with those of intra-arterial anomalous origin of left coronary artery due to high risk of sudden death. Overall, there is variability in the surgical referral patterns, but the large review of the Congenital Heart Society and intramural or intra-arterial course with the strongest predictor of the referral of the surgery. The optimal management of the asymptomatic patient with AAORCA or AOLCA with intraseptal, prepulmonic or retroaortic course is less clear. But the current AHA guidelines recommend the observation with the stress testing as a part of the medical clearance for athletes. Coronary angioplasty with stent deployment has been used. However, without the large scale of studies with a long follow-up, it can be considered for symptomatic AAORCA as a result of contraindication to the children. And multiple surgical techniques can be employed to address AOCA. So the first strategy is unroofing. This is the most common used surgical therapy for AAOCA, and the anterior aortotomy is performed and the portion of the coronary running under the aorta is unroofed by excising the intervening wall between the aorta and the anomalous coronary artery. The advantage of unroofing include the relief of the potential osteostenosis, relocation of the orifice to the opposite sinus, and elimination of the portion of the vessel between the great arteries. And there are several potential pitfalls of the coronary unroofing. First, if it has an intramural course, including the intracoronary commissure, there is a risk of creating aortic insufficiency by damaging this commissure, and it can be addressed by resuspending the commissure or limiting the unroofing of the arterial component, and that is not behind the commissure. The second pitfall is the potential for dissection at the excision point, and which is generally prevented by packing, tacking sutures, and new ostium. And lastly, the aggressive unroofing can lead to full thickness incision of the aortic or the coronary wall, and care must be taken to avoid this. Pulmonary artery translocation, and if the compression between the arteries is believed to be contributing ischemia, the main pulmonary artery can be translocated, and there are two general strategies. By both begin with full mobilization of the pulmonary root. Next is the main pulmonary artery is transected and then anastomosed to a patch new confluence, moving the main pulmonary artery afterward to the leftward. Alternatively, the proximal right pulmonary artery can be divided and then translocated anterior to the aorta and reanastomosed with an anterior patch to prevent stenosis, and this variation moves the main pulmonary artery anteriorly. In both instances, the main pulmonary artery is moved away from the intra-arterial coronary and thus preventing the compression. Reimplantation, this strategy applied when there is no intramural course and there are two separate ostia. And in this, the ideal situation, the anomalous coronary artery is mobilized, excised with the rim of the aortic valve, and then implanted with the appropriate sinus. Autologous pericardium can also be used to augment the implantation site, and this strategy is technically challenging, and there is a risk of anastomotic stenosis and the coronary kinking with the application. There could be osteoplasty. The strategy can address the osteostenosis as well as the intramural and intra-arterial coronary course. An anatomically correct sinus is incised and matching incision is made in the coronary artery, and these incisions are then joined and augmented with the patch and thus creating a new ostium. The technique is generally the most challenging from the technical perspective, and visualization can be augmented by transection of the main pulmonary artery. Coronary artery bypass grafting. This technique is not commonly used due to largely limited bypass conduit longevity issues and competitive flow between the native coronary artery, and that is unobstructed from the time and the bypass graft. Some advocate the ligation of the native vessel at its origin, but this remains the concern about the insufficient flow from the memory artery graft where compared to the native unobstructed coronaries. As such, the strategy is generally reserved for the cases of AAOCA and atherosclerosis of the native coronaries. Coronary artery fistulas are commonly originated from RCA and most frequently drain into the right-sided chambers. The clinical presentation varies from the size of the fistula. The patients are usually asymptomatic, and the anomaly may be found incidentally and a continuous murmur. If the fistula is large, the patient can have a significant left-to-right shunting, causing a myocardial ischemia secondary to coronary steal and leading to heart failure. Transthoracic echocardiography is usually diagnostic, but the cardiac catheterization may be necessary. Treatments include the surgical percutaneous closure. Surgical closure techniques may vary by a specific site of the fistula, and of note, the cardioplegic arrest is required when the procedure is done, and the fistula should be compressed and ensure adequate myocardial protection. Thank you.